The next 2 years are likely to bring unprecedented challenges to healthcare in Minnesota. We'll hear from insurers, the business community, and hospitals about how things stand in the state as 2025 closes and 2026 kicks off. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm Tim Nelson. In this episode, we'll listen to a recent Fluence Forum focusing on healthcare hosted by Fluence Media. The experts included Minnesota Hospital Association Vice President of Finance Joe Schindler, as well as Lucas Nesse, CEO of the Minnesota Council of Health Plans, and Brindley, a former legislator and health policy director at the Minnesota Business Partnership. Jim Schowalter, former state finance commissioner, former senior vice president at Health Partners, and Nesse's predecessor as CEO at the Minnesota Council of Health Plans, moderated the forum.
We've got three panelists here who are going to help explore, what should the state do given the landscape that's already been laid out. We have large integrated systems. We have strong public programs. We also have high costs and persistent disparities. Almost on a regular basis, we cycle between issues. Where should we be turning going into the future, given all the context of the industry change and things that are going on that have already been laid out for us? So around the horn, let's go. We'll start with Lucas Nesse. Lucas has experience in the Minnesota legislature, at the Minnesota Business Partnership, and is president and CEO of the Minnesota Council of Health Plans, the local nonprofit insurers. Welcome, Lucas. How does your organization view today's healthcare market in Minnesota?
Thanks, Jim, and thanks, Fluence, for hosting this forum. I think you started this day calling the state of healthcare chaotic, and I think everyone on this call essentially agrees with that status as of today. I think we have to be hopeful at the same time. There's a lot of smart people, good people engaged. As Jim said, the Minnesota Council of Health Plans is the nonprofit health plans based in Minnesota. And just to put some perspective around that, the nonprofits exclusively serve state public programs that have been a huge topic of today. 95% of the fully insured market is through the nonprofit health plans, and a big portion of the self-insured, generally the largest employers in the state, are also through the nonprofit health plans. So everyone on this call talks a lot. There's a lot of smart minds, good minds, well-intended minds trying to figure out these big challenges. But really, it starts with that big, beautiful bill impact as far as the immediate concern. But there's underlying challenges as well that we're all very well aware of and working on as well. But thanks for having me.
Absolutely. Thank you. Ann Brindley is an expert and has a number of different and additional perspectives on the topic. She's been a legislator, elected to the Minnesota House, has served in both the Health and Human Services Policy Committee and the Finance Committee, was Deputy Minority Leader, and now is with the Minnesota Business Partnership as a policy director. And it's a really, a great mix of perspectives. From your perspective, what is your view and your organization's view of today's healthcare market in Minnesota?
It's interesting. I represent actually the largest employers in the state of Minnesota, right? We employ collectively about 1/6 of Minnesotans, and that also means that we insure far more than 1/6. We insure their families. And so we care a lot about the state of healthcare. And you talk about this healthcare market. And the way in which I talk about the market is that we actually have this really delicately balanced sort of ecosystem that actually should matter to every Minnesotan. And everyone, I suspect, on these different panels today will agree that our system is not perfect. The cost of care is expensive. The cost of insurance is expensive. However, we should all be very concerned about the stability of that market, because the reality is right now, even if you include the state of Minnesota as an employer, they employ about 50,000 people, but that means over 50% of Minnesotans receive their health care at no cost to the state. They do not receive public programs. They are not involved in the individual market. They receive their care at no cost to the state, which is a really big deal. So when we start talking about things like expanding Medicaid for all or a public option buy-in, that really interferes with this delicate system that right now we all rely on, and it will affect things like the cost of care, and perhaps more importantly, access to care. As providers, we've got Joe with the Hospital Association. I mean, as providers receive lower reimbursements, it's going to be much more difficult for them to keep their doors open, to manage every service line. We will have a real problem with access to care. So when I think about the market, I think a real delicate balance that we all have an interest in maintaining.
That delicate balance makes a total sense, resonates with all the discussions that have come before us. And Joe, I'm guessing that you might agree with that as well. Our third panelist is Joe Schindler, Vice President of Finance at the Minnesota Hospital Association. Joe, you've been in healthcare for a long time. You know it and know that balance very well. Just to give us your thoughts about MHA and your perspective on Minnesota's healthcare market today.
Yeah, well, first, thanks for having us on, and I will say that MHA represents 140 hospitals and health systems across the state, largely not-for-profit employers. In fact, our hospitals and health systems are some of the largest health employers in the state, and including at the community level, usually first or second largest employer. So we're a big economic engine, but we're also a large provider of healthcare. And I have concerns, in my 38 years, this is probably some of the worst and most fragile financials that we've seen over that time period, especially since COVID. But in more recent years, our latest margin data shows that over 40% of hospitals were losing money, and most of those were in rural areas, but some in the metro area as well. So it's spread across the continuum here. These financial struggles haven't left any stone unturned. So that's part of the issue that we're seeing going forward. We have tried to figure out ways to balance the books a little bit. There's been a historical issue of cost shifting where the Medicare and Medicaid programs have historically underfunded the provider community with the social contract, so to speak, in place that those costs would be recovered on the commercial market. But that's no longer there's no longer ability to do all that cost shifting. Why is that? Well, in part because we've got a payer mix at hospitals that is at about 64% of the payer mix and growing. So if Medicare and Medicaid are the highest proportion of patients coming in, and you lose money on every one of those patients, it gets more and more difficult to balance the books. The other thing that we have worried about is, okay, well, can we balance those scales a little bit? Can we get Medicare to pay more to pay their fair share of the cost? Can we get Medicaid to do the same? And so in sort of an act of desperation last year, we initiated a directed payment program in the Medicaid program. And this is something that 40 other states have implemented. And it comes about when you're not able to get the state legislature to put up the money, the state share of Medicaid funding, to leverage the federal share, then the hospitals have to kind of look to themselves. Can we finance that state share on the state's behalf, and then leverage the federal share to come in and make improvements to the Medicaid program? So the good news is we got bipartisan support last year. We got it through the legislature. We were able to get that passed. And then in addition to that, we got the state of Minnesota Department of Human Services to get the application in, what's called a preprint to CMS, prior to the passage of HR 1. So all that is well and fine. We thought we met all the rules and known at the time. And now we come to find out that CMS is seemingly reinterpreting the rules in what they're going to allow and what they're not going to allow. So we in Minnesota may be stuck back at ground zero with a program that should have been allowable, and yet we're struggling to get CMS to make that approval. So that's one of the big challenges that we see on the horizon, besides the other factors in HR 1, which, with Medicaid disenrollments, we have some great concerns about where do patients go when they become uninsured. They're going to show up in the emergency room. And so that is, I think, like Ann mentioned, it's going to be a cost on everybody, because when you put those kinds of financial pressures on hospitals, it is going to translate into cost to everyone else and potentially the loss of services if the hospital financials continue to crumble as they have been. So I'll pause there.
That is a really useful introduction, and I think each of you brought out themes that we're going to keep on exploring. Whether it's the payment mix and the fragility of the system, it's the delicate balance of payments and who's paying in the marketplace. That's really both in provider side and on the insurer side, has a lot of nonprofits trying to make sure that this all works out. Joe, you mentioned dollars and cents. And so I'm going to just start with one of those easy questions or easy places, which is, how does the state going to pay for its share? How is it going to do more for healthcare to get through the changes in federal payment changes or market changes? And just give everyone a little bit of context on the forecast. The couple of statements from the recent forecast just the other week said that, quote, Minnesota's budget and economic forecast remains stable in the current biennium. However, structural budget challenges remain. Also says there's a projected surplus of $2.465 billion in the current biennium. It goes on to say that higher healthcare costs and slow economic growth drive increased structural imbalance in the FY 28-29 planning estimates, where the balance is now projected to be a negative $2.96 billion. The Healthcare Access Fund, another source of funding for healthcare, has a small deficit this biennium that grows almost to a $500 million deficit over the forecast period. So that's not really going any different direction, any better direction. In sum, the state has some money now, but expectations for current law healthcare services and other activities are not sustainable without some changes being made somewhere. Given that context, Ann or Lucas, how do you respond? Where do you think you and your organization would point legislators and the governor to start looking at how to make healthcare more stable and more accessible given this financial environment?
Yeah, I can jump in on that, and maybe to put some more perspective around that rapid growth in state spending. I looked at the chart, and it's a biennial budget, mind you, but it generally follows the calendar year. In 2015, the Medicaid budget was $15 billion. In 2025, it's approaching $25 billion, and it's on pace to be $30 billion in 2030. So when you think about that growing pressure, it crowds out other priorities that you're hearing from legislators that they want to prioritize first, but it requires cuts or tax increases to pay for it all, or adjustments within. And from there, you're looking at the benefit set. And one of the kind of big examples that you see within Medicaid as compared to commercial is the coverage of GLP-1s. It's just one example that's relatable as a hot topic out there. That's an $80 million biennial budget impact for the coverage of GLP-1s for Medicaid. That is something that commercial, by and large, does not cover, perhaps due to the cost pressures that it puts on the system. So that's just an easy place to start. One of the last meetings before COVID, actually, that we had with a broad group led by the chamber was about low-value care. So as people think about trying to right-size systems, there might be an opportunity to revisit low-value care, which is defined as care of little or no value or excessive treatment that is generally recognized to be 20% of expenditures out there. So there's ways to kind of approach these financial pressures without upending the system completely in a very appropriate manner to ultimately support efficient, effective care.
Yeah, I can jump right into, Lucas used the example of GLP-1s. Insurers use sort of the metric of per member per month. What's the cost per member per month? GLP-1 coverage started at $1 per member per month. It is currently $47 per member per month. I was in another meeting yesterday where someone shared that and my jaw dropped. It was shocking. And I think, it doesn't mean that we shouldn't cover medically necessary tools, whatever those may be. And for folks who are high at risk for other health-related issues based on weight loss, diabetes, whatever it may be, it's probably worth covering. You talk about that high value care. That's probably worth covering. However, the very broad access maybe should be reconsidered with things like that. I would also, mention, I think we would be remiss if we didn't address the elephant in the room. There have been a lot of Medicaid dollars being lost in the state to fraud. Now, fortunately, I think that it seems that everyone is taking that seriously at this point. But I mean, we're looking at over $1 billion, our conservative estimates. That is a lot of money. I suspect Joe would say that our hospitals would be thrilled to have that money to provide care to Minnesotans. So I think that as we see sort of some of the things go into place to detect, prevent fraud, of course, Lucas working with the health plans, they've been doing this for years. That's what they do. I think we'll find some additional, money in the couch cushions there. And then the third thing that I would talk about is we have to find efficiencies in the cost of care. We talk about Medicaid determinations and redeterminations. And, like you said, we've got $2.4 billion. That is what we call one-time money in government. That is not going to be available to spend over and over and over through the years. And we need to start investing in our unbelievably archaic and outdated technology systems in this space. With House File 1 coming down from the feds, these determinations are going to have to be done twice a year. There's new workforce requirements that are going to have to be verified and managed. That will come at a cost. We have to find some efficiencies in technology. We've got to update our technology, and this is a perfect opportunity. We've got that chance right now with one-time money to spend that will pay some dividends in the future as we find some efficiencies there.
Those all sound like great topics and totally things that I could imagine the legislature getting its teeth into. Joe, I want to give you a slightly different question, which is scale is always really a hard thing to get your hands around in healthcare, of where all the dollars are and big dollar amounts going through every day. From the perspective of hospitals, how do you start changing on a repeating basis year after year that growth in healthcare costs that was showing up in the forecast? Are there actions that could enable the industry to do things better?
Well, I think both Lucas and Ann hit it on the head. It's pharmaceutical costs are going through the roof right now, and it's not just the GLP-1s. And so, in fact, when we look at the hospital cost structure, it is pharmaceuticals that are driving the largest share of increase in costs year over year, but by double digits. And that's part of the why the math doesn't work for hospitals anymore. The revenues have been somewhat constrained, and yet the cost side with labor increases and material and all the purchase services, including drugs, have gone up at a faster pace. So definitely agree with that drug cost problem, and we need to somehow get a handle on that. And that's despite the fact that 95 of our hospitals are involved with the 340B drug discount program, and still those prices are increasing. As far as getting a handle on the costs, again, I think part of it is the financing mechanism is imbalanced right now. Like I mentioned before, if Medicare and Medicaid could pay their fair share, the commercial rates could come down over time. And yet we just haven't been able to get there. So that's one way of looking at it. Because you look at it from a patient perspective, especially a commercial insured patient where they're paying a high portion of the cost because deductibles have grown quite a bit. They're expected to pay a lot more out of pocket. Part of the reason they're seeing such high costs is that on the other side of the equation, the Medicare and Medicaid programs aren't paying their fair share. Otherwise, some of these costs could come down. So that's some of what we see. As far as long-term cost, curbing the growth of cost, there has been work going on over the last 10 years. Most of our hospitals and health systems in Minnesota have been involved with value-based purchasing programs. It started with Medicare, where they set a target, per population price. And if you can meet that price, then you share the savings with the federal government. And that transferred to the Medicaid program. We've also got some commercial programs that are value-based programs, but they're still relatively small components of the overall structure. The key point, though, is it's at least recognizing we got to do a better job of paying for keeping people healthy and out of the hospital rather than just treating people as they come through. So that could have some effect down the road. I don't know if value-based care is the ultimate solution. There may be a step towards a better solution than that, but certainly that has been at least curbing the growth of cost over time.
To help our audience get a sense of that difference in prices, Joe or Lucas, because you probably have up-to-date information, but I remember that in states across the country, the price that is paid by a commercial insurance contract is markedly different than what's covered by Medicare. But states have very different Medicare reimbursement rates, sometimes close to what a commercial insurer pays, sometimes not so close. In Minnesota, not so close. Then Medicaid might be close to what a Medicare payment is, or sometimes not so close. Could you give us a sense of how those payments come together? Because like when I go and get a package of carrots, and it's $1.89. It's like, I don't expect to see it for $12 at another place. But in healthcare, it's a little bit more like that. Lucas, do you have any sense of those ratios, or Joe?
Yeah, I know, Joe, you have MHA does a kind of below cost matrix on Medicare and Medicaid payment levels. I know that the commercial level is roughly 210% of the Medicare to make up for that cost shift to actually sustain access to care, which is part of the partnership of making sure that those Minnesotans aren't caught up in the middle and not getting access to their appointments. But so commercial generally 210% of Medicare. Joe, I think you have a number on cost, so I can defer back to you.
Yeah. In the Medicaid program, we estimate that the Medicaid program is just across the state, on average, is paying hospitals pretty close to 30% below the cost of care. So 30% below cost. And then you've got the Medicare program, which is on average reimbursing hospitals about 18% below the cost of care. So those are the two, below cost big payers that comprise 64% of the market or payer mix.
So, who is paying makes a lot of difference, as well as how much care is being provided. So, Anne, you started talking about how important, your members are paying for half of the healthcare in Minnesota and more. And yet we're sort of at a crisis point. Do you see we're at a turning point? How worried are you about that balance in the marketplace and the providers, the insurers, the stability of this overall structure given changes in competition, in federal payments, and just growing costs?
I really appreciate this question. I think that as Minnesotans, as Americans, frankly, um, we need to start having some real conversations because we don't. I mean, we talk about the cost of prescription drugs and pharmaceuticals and how much that is driving up the cost of care. And people, average Minnesotans would say, well, yeah, it's so much less expensive in Canada. Why don't we get the same benefits? Well, Canadians have access to about 40% of the medications that US citizens have access to. We have access to a far different level of care. You talk about the cost of labor. Joe talked about that. Labor is expensive. In Minnesota, when you adjust for cost of living, we pay our nurses higher than anyone else in the country. That's expensive. And particularly when you want to compare that to other countries, I mean, you look at the UK, a physician makes about $100,000 a year. Well, they're making far more than $100,000 a year here. We are paying for choices that we have made. As Minnesotans, when we go to the hospital, we probably have a private hospital room. And we'd be really upset if we didn't. And so when we talk about these costs, yes, it is expensive, but we are getting something for that expense. And if we want to make different choices, then we should have that conversation. But just blaming the current system, blaming our hospitals, blaming our insurance companies, it's probably not a real fair way to evaluate the system. I mean, Lucas represents our nonprofit insurers. They have about 3 months in reserves. That's not much. I mean, this balance can be upended quickly, but we talk about the costs without talking about what we're getting for those costs. And I think so far, Minnesotans, Americans have been willing to make that trade. So if we want to really talk about bending the cost curve, this is a much bigger conversation than just sort of this delicate balance, which I think really matters. Because like I said, the bottom line is 50% of Minnesotans at least are getting their care at no cost to the state, and they're getting really good care. We don't hear about the 95% of Minnesotans who receive their care without incident. You hear about it when there's a problem, but the vast majority of the time people go to hospital and they get the care they need. They submit the claim to their insurer and it's paid. The vast majority of the time, that's the case. But we have a real public perception problem, I think, in this conversation that we need to start addressing.
Lucas, do you
So
have something to say?
just one observation that I think, sometimes it takes a crisis for, big change to happen or to problems to get addressed. And I think to, kind of expound on Ann's point, employers in Minnesota are pretty generous in shielding their employees from a lot of these costs. 90% of premiums paid by the employer monthly. And where you see this crisis is in the first showing up is in the individual market where the employers don't exist. These people are buying it on their own and they don't have somebody else paying that cost. And that's why a relatively small part of the market is talked about so much because that crisis exists already. Whereas I think you're starting to see these small employers starting to struggle to share those costs and cover those costs for their employees. That's where you see higher out-of-pocket costs. And it's just kind of spiraling. And, I think everyone here is trying to address that before it gets to a crisis mode in those employer markets as well.
So let's focus on the positive. What can we do? Because Minnesota has a rich history of healthcare innovation and delivery, has a deep bench of expertise in a lot of different domains, and the state can't really fix everything. It has a limited set of tools it can do, and legislators are coming to the Capitol this session, and all kinds of changes are ahead. So what are the things that the state should be focusing on? Is it payments? Is it program structure? Is it eligibility? Is it regulatory? The answer is probably a little of all of them. Is it data? How would you help somebody focus and think about creating an agenda for stabilizing and improving Minnesota's healthcare landscape going forward?
Well,
Joe
Jim,
looked like you wanted to jump in. Go for it.
sure. Yes. You mentioned some good points there, Jim. And one of them is data. One of the things that hospitals and health systems have learned in the value-based purchasing work that they've done is they've been able to get a clearer picture of where do their patients go if they're not within their system for care, and how do you manage keeping people, healthy within your system, or if they need a higher level of care, how do you get them transferred? And quite frankly, before all of this, they were flying blind. We were like just takers of care. If somebody gets sick, they show up. It was hard to know what they were doing outside of your own organization. So there could be a way to bring more organizations into value-based care and part of that is through data. We need better data sharing among the health plans and providers so that there's better coordination of the care. For number one. The other thing I wanted to just mention, what can legislators do in this next session? Given the fact there is a little bit of one-time money, I think since we do have some concerns on a couple of fronts, I definitely agree that getting the state to bring their 36-year-old Medicaid redeterminations enrollment system up to speed so that we're not using dot matrix printers or whatever, black and white screens to qualify people for Medicaid. I mean,
Those green screens are great, Joe.
Those greens, unbelievable what we've heard from the counties. And we definitely support the counties and what they are doing to work with the state to try and get some better IT infrastructure in place, because that will not only help with getting people into the system and running more smoothly, it will eliminate some of the fraud that's been going on in the system as well. Because right now, even with the technology we have in place, there's no cross-checking of whether somebody applied up in Pennington County versus McLeod County. I mean, it's crazy what they've got in place right now at not being able to cross-check some of these data points. So to that end, we think the state needs to pony up some money to bolster that system. We also think there may be a need for at least some one-time money for hospitals to treat those that are going to fall inevitably through the cracks and end up uninsured and in the emergency room, which is where anyone would go for their safety net. And so if there was one-time money, either for that and or the fact that we anticipate that with the UCare wind down, I think a lot of providers are going to be stuck holding on to some bills that are never going to get paid. And so there's going to be some fallout from that. I know there is some state backstop on the commercial side of the UCare situation, but maybe not so much on the Medicare and Medicaid side of the UCare wind down. So we have some concerns about both those factors. And so some one-time money might at least stabilize the system for a year while we get things under control with regard to technology and a more streamlined way of getting and keeping people on Medicaid or kicking people off that shouldn't be on there. So,
And you introduced this whole topic of county eligibility determination, all the work that's out there. Yeah, how do you see us getting from a theoretic change where people have different roles and responsibilities to one that is more efficient that we all want? I think I haven't met anybody yet for the last decade who doesn't want a more efficient, streamlined eligibility determination system. Yeah, we haven't gotten there. What do you think is going to be necessary for us to get there?
Well, oh, sorry, Joe.
No, go ahead.
You kind of hope that this is the exact kind of setup this year in the legislature, that this gives us the exact kind of setup we need to get it done. There's $2.4 billion in one-time money. You can only spend it on things that have a contained cost, not an ongoing cost. And an IT system like this, well, yes, there's money for maintenance. There's money for maintenance right now. So that shouldn't change long term. The problem that we have in the legislature is the legislature is by its very nature a partisan organization. And right now we're in a situation where the Minnesota is so unique, right? We've got 201 legislators, and the majority is the difference in the majority is literally 1 out of 201 legislators. And therefore, political priorities for one side or the other are very, very difficult to get done. And so we've got $2.4 billion. No one disagrees that the system is, I mean, it really is archaic. Like you said, green screen, DOS. I mean, you've got county workers who have 3 computer screens up and they are manually transferring data from one screen to another. I mean, it's nonsense. It really is an embarrassment. But this is the kind of year that you think, okay, can we come together and do something that is just not sexy at all? It's not political at all. It just needs to be done. But from the Democrat perspective, ideally, they will look at this technology and these upgrades as a mechanism to make sure that people are not falling through the cracks and that people are going to continue getting the coverage and the care that they need. From the conservative Republican side, hopefully we're looking at this and saying, we need efficiencies, we need to save costs. And this is a way to do that long term. We're not finding more workers, we're not finding more bodies. They just don't exist. And therefore, we need to give everyone the tools they need to get the work done with the constraints that they have. Like I said, I would hope that the current conditions in government would create a perfect environment to just get really good work done that isn't political at all, but benefits the whole state.
That is a wonderful take on it, and you're right. Yeah, the opportunity for working on something that there's not a big win for anybody on, on desktop in county eligibility offices, but it is a great opportunity, I think, that everyone's seeing. Lucas, I want to ask you about regulatory reform because it's another non-sexy topic. It's not about dollars and cents, but it does talk about how your members and the entire healthcare system works. Are there other non-sexy things that the state might think about going into this session in the next few years that might help us be a little bit more nimble, might help us do things a little bit easier, maybe a little less duplicative going forward?
Yeah, Tom Lindquist earlier mentioned we need to start managing wellness, not sickness. And I think you've seen the trajectory of regulation pushing this health plan towards sickness and more of a payment processor as opposed to supporting care coordination or utilization management. And I'm hoping that, to Ann's point, there's a way to thread the needle and kind of bring together keeping people covered with appropriate oversight to try to, pair keeping people covered with clamping down on fraud and efficient, effective care. That utilization management plays a big role. I don't think that prior authorization is ever going to be sexy again. But I saw it in a column yesterday where someone called it like prepayment review. So all right, let's rephrase it. And to Joe's point, these value-based arrangements can be accomplished with little or no prior authorization as well. There's ways to appropriately do this. Again, the nonprofit health plans cover the huge portion of the state. We can work together to find that appropriate oversight. Again, the easy example is weight loss drugs. Works for some, doesn't work for others. At what point is it fair to recheck and continue to authorize that coverage or not? I think everyone can agree at some point it is appropriate to insert and review and make sure that it's working or not and try something different. It's just a simple example.
Outstanding. This is a great conversation about the sort of the balance, the tensions that our payers, our insurers, our providers are making to pull this all together. Hopefully, we've given you a little bit of ideas of where the state may be focusing going into the future.
Again, that's former State Finance Commissioner Jim Schowalter moderating a Fluence Healthcare Forum discussion recorded December 16th. I'm Tim Nelson, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.